The following was recorded at the CCHF Conference 2023 in Cincinnati.
Well, good morning, and you are faithful. The remnant, about this time at CCHF, people start disappearing, heading to the airport and everything. Or maybe you just got stuck. All the good flights were taken, and you're going to stick around at 8 o'clock tonight. So my name is Bob Mason, and I'm just going to do a quick scan. Have some students here. How many of you are working in underserved clinic settings? Okay, several of you. And in direct patient contact, like healthcare? Okay, all right. Well, good. Well, thank you for the work that you're doing. I know that the population and serving the underserved brings a lot of challenges, and I am incredibly grateful for the work that you're doing and the commitment. I work with an organization called Medical Strategic Network. We're best known for doing training in the area of whole person care. I've been involved in this training for about 25 years. People ask me, are you a physician? No. Are you a nurse? No. Are you in healthcare? No. It's like, well, how'd you end up doing this? And it's like, God. And so anyway, I'm looking forward to our time together. I am married. My wife and I have been married for 33 years. We have 2 children. And if you've ever been around children, you probably have, maybe some of you have children of your own. You know that as long as you give your kids, give them some water every day and maybe feed them 2 or 3 times a week, they grow up. And this picture was taken at these pictures. One of my favorite places on there, Coronado Island, which is just across the bay from San Diego. So if you ever get out to the West Coast, check out Coronado. That's a more recent picture. And my son and daughter-in-law are holding their 3 grandkids. It's birthday weekend at their house in San Luis Obispo, and my wife is there, and they're out on the beach, and they're having a pirate-themed birthday party with buried treasure and eye patches and telescopes and all that other stuff. My daughter is down on the far right side with her husband. My daughter is a nurse, and so know a little bit about that world from educating a nurse and writing the checks for nursing school and all of that stuff. And she was working on a telemetry unit in March of 2020 on the West Coast, and that man walked onto her floor and just sort of waved her hand and said, "You guys are the new COVID." And she was taking care of COVID patients at the beginning when they said, "We ain't got no PPE for you." But she did that for 2 solid years and never got sick. And so we were incredibly grateful for that. She has recently transferred to an OB unit and helping with moms and newborns. A little bit of perspective. I don't need I do this presentation at secular health science campuses, but I'm going to be coming from a definite perspective today, and that is a Christian perspective. And I don't think I need to apologize to CCHF for that. I don't want you to, get all uptight. I'm not going to try to force my ideas on you. That will think creatively. But what I do hope is that I can share some information with you, and at the end of our time, you get to decide whether the perspective that I'm coming from and the things that I'm suggesting would be worthwhile to you, and how you take care of your patients, and you get to make the decision. I have no disclosures. I want to tell you a quick story. Right before the pandemic, I was training some med students. This was part of our whole summer whole person care preceptorship, and we walked into a patient's room at a major medical center in Southern California. There was a lady in the room, and she was about 28 years old, and we introduced ourselves, briefly explained why we were coming to visit, and that is we're doing some training, learning how patients cope with emotional and spiritual issues, how when they're ill, and these are some med students who are learning how to take a spiritual history. Would you be willing to help us out? And not part of your healthcare team, we can stop at any time you want, and so we introduced ourselves. She looked at us and she said, "I am in the hospital because God is punishing me because I had an abortion when I was 28 years old. A lot of clinicians would have just sort of brushed that aside and said that has nothing to do with why you're here, years later. We didn't see the chart, we didn't know what was going on, but to brush that aside could have had significant consequences. And like I said, a lot of people wouldn't know that. Well, these students didn't. They took a spiritual history. As they said they were there to do. And questions like, has any of this been scary for you? This illness, this hospitalization, what's kept you going? How is this illness, this hospitalization, affected the way you see yourself? How has this affected the way that you think and you relate to God? And those questions are designed to find out what is the patient's coping system. Is faith a part of that coping system? Are there some spiritual needs there? Does the patient recognize those needs? Does the patient want to have those needs addressed? And do they give consent to do that? And as we went through those questions, it became very clear that this lady, we'll call her Susie, had some spiritual needs. It also became clear that she was open to have and recognize those needs, and she was open to having those needs addressed. And within a few minutes, we were in a further conversation, and of course, given what she had told us, we could see that forgiveness was a big issue to her. And forgiveness, and the other thing we found out was that she was estranged from her dad. And she said, we said, well, where is your dad? She said, well, I don't even know where he is. I know where he works, but I haven't seen him. Don't know where he is, don't know where he lives, don't know his phone number. But she said if he knew I was in the hospital, all this stuff we'd gone through, he'd be here. And I just sort of casually remarked, I said, well, social services would work with you on that. And we continued the conversation and back to forgiveness and all this. And would it be helpful if we talk to you about how you can experience forgiveness from the Creator God and have a relationship with that God? It's just like, yeah, really would. And so we had this conversation and ended up being incredibly fruitful. She was very interested in Christian perspective and how Jesus was a part of that. And so in a few minutes we actually not led her, she prayed and said, God, I want that connection. I want that relationship with you. I want to know that my sins are forgiven. And thank you for what Jesus has done for me. A few days later, we came back to check on her. And we checked with the charge nurse. Is it okay if we go in to visit? Well, she had some company. Let me see if they're gone. Well, who was the company? Well, it was her family. Was her dad there? I think he was. And so the family had left, and so we went in to see her. You remember us? Oh, yeah. You remember what we talked about? Yeah. And she unpacked, almost word for word, what I just told you, in terms of this is what we talked about. And we talked about some resources that would be helpful to her in terms of her own spiritual growth and some other things. And then as we were leaving, she told us, she said, I had no idea what I would have done if you wouldn't have come by and talked to me. And here's what I'd like you to do. I'd like you to get in groups of 2 or 3. And I'd like you to talk about what you heard. Honestly, authentically. What did you like about that story and that encounter? What did you not like? What questions do you have or what concerns do you have about this story? And you're not going to offend me. All right, ready? Go. 30 more seconds. Well, why don't we come back together, please? What did you come up with? Start positive. What did you like or appreciate? Nothing. All right, we'll
Did
move
you
on.
ask for consent before you opened up any conversation?
Okay, yeah. Tapping in and recognizing the patient autonomy and the importance of that.
We also like how you introduce yourselves and what your goal was for being there.
Yeah.
You're, not necessarily part of a treatment team that will affect direct care.
Right, yeah. Yeah.
We decided that we liked the way the patient was, even though the way she presented it, she still had the courage to say it.
Yeah. Yeah.
She initiated the conversations.
Yeah. Yeah. Any concerns you had? These are a little, I don't know.
Question about
Yeah,
it.
okay.
If she had been defensive, maybe she was willing to talk with you but been defensive, how do you deal with that?
Can I save that question a little bit later? Yeah, and remind me when we're talking about the pain in my side, if I don't answer that.
Like to be followed up.
Followed up, yeah. Oh, yeah. Yeah. Yeah, that was really good to be able to do that. You can't always do that, even with your own patients. But I heard maybe the previous session or somebody said they're a hospitalist. They're there, you go home, come back a couple of days later, they're gone. So, you can't always do that. One of the questions or concerns, frankly, you should have had as you listened to that story. Well, yeah, that sounds really cool at CCHF. Maybe at our faith-based FQHC or faith-based, privately funded, right next door to the church with a cross in our building. But is that ethical? Is it legal? Some people have wondered, will I get fired or lose my license or something like that? And that's where I sort of want to go next. I want to look at some peer-reviewed evidence, and I want to try to very briefly argue that what we're talking about in doing whole person care is ethical. In terms of your peer reviews, or your peer perspectives, in one survey, 75% of surveyed physicians agreed that religion and spirituality is important to patients for coping and for giving them a positive state of mind. So your peers, although they might not have that same faith, recognize the value of it. Patient satisfaction, which it became even more important when the Affordable Care Act was passed because patient satisfaction is now linked to reimbursement. Patients who had discussions of religion and spiritual concerns were more likely to rate their care at the highest levels, regardless of whether they had said they had desired such a discussion or not. Patient views, and this, I think I put this on the website, a link to this article or study that came out in JAMA last summer. A really robust study, and all of you need to download this and read it. But Tracy Balboni, oncological palliative care physician at Harvard Med, and a bunch of others got together and they looked at, started out I think with 10,000, they did a meta-analysis, 10,000 articles that dealt with faith in medicine. And they ran them through a Delphi panel, and they came up with 300 of the best of the best of the best of the best. And they published this in JAMA. And one of the things that they found was that spiritual care is frequently desired by patients during serious illness. That 50 to 96% of those patients want that. But there was a significant disparity because the spiritual needs are infrequently addressed in medical care of seriously ill patients. Roughly, that only happens in 9 to 51% of the patients. So you have this huge disconnect between what patients want and what patients actually get. Well, is faith even good for health? Religiousness is related to significantly less depressive symptoms, better quality of life, less cognitive impairment, less perceived pain. And the Journal of Rehab Medicine says clinicians should consider taking a spiritual history and ensuring that spiritual needs are addressed among older patients in rehab settings. So faith can be actually good for you. Now this is significant. And this sort of ties into what Susie was dealing with, although she doesn't fit the age category. 2-year longitudinal study of elderly hospitalized patients found that if patients, while they were in the hospital, wondered whether God had abandoned them, they questioned God's love for them, they decided their illness was a result of the devil making this happen, or they felt punished by God for their lack of devotions, those patients, if they dealt with that, would see a 16 to 28% higher mortality during a 2-year period following hospital discharge. Now, Susie wasn't in that age category, but I think there's probably some indication that they could have had some adverse effects that hadn't been addressed. Walt Larimore, a family practice doc in California, a friend of mine, said that if you knew something increased the likelihood of dying by 20%, would you intervene? Well, if you're my healthcare professional, I hope you would. You know, please. Well, if whole person care is not done, is there a cost related to it? In End of Life, again, Balbonis and some others at Harvard did this study. End of life costs were higher when patients reported that their spiritual needs were inadequately supported. I'll let you read the numbers there. So in some situations, whole person care actually reduces the cost of care, which is a huge concern for everybody. The Joint Commission, organization that accredits hospitals. When I'm training students that come in for our summer preceptorship, I say, tell them, if you see the Joint Commission on the unit, run, just leave. But they have all these guidelines, as you know, about what's required for accreditation. And historically, they have said that the spirituality of patients should be respected, assessed, and attended to in ways that are important to them. Now, to be fair, I think they're softening their stance on this. They're only saying that this is absolutely required, I think, in mental health issues and maybe end of life. But to me, that a secular entity has recognized the value of whole person care is pretty significant. Now, that they require this or have required this does not make it ethical. If they stop requiring it tomorrow, that doesn't mean it becomes unethical. But again, it's just interesting to me, secular entity has recognized the importance and said, hey, you need to do this if we're going to give you our little star. Puchalski at George Washington University has noted that in palliative care resolution, the World Health Organization says that it is the ethical obligation of all healthcare professionals and healthcare systems to address spiritual issues. American College of Physicians has a similar general statement about that. And then another cancer organization supports this position. So again, you see these professional entities saying, yeah, this is important. So, where does that leave us? Again, get back to your little discussion groups. What do you think about what you've just heard? And what do you think about what you just heard as it relates to doing whole person care? Ready? Go. Give you about 2 minutes.
Sort of sounds or whatever, just like something about that.
A lot of the time, it is sort of difficult to assess what they Is it 30 or and that's 50.
Well, let's come back together, please. So we talked about taking the spiritual history. We talked about trying to assess spiritual needs of our patients and get to see if we need to address those needs. And how do we do that? Well, we ask. Here's the spiritual history that we use. Some of these questions are original to Medical Strategic Network. Some are borrowed from other spiritual histories. If you go to PubMed and you type in spiritual history, you'll be surprised at how many hits you get. There are a number of models out there. I think one or two of these questions came from the Joint Commission suggested questions. And so again, what these are designed to do is to try to find out what is the patient's coping system. Is faith a part of that coping system? Are there some spiritual needs? Does the patient recognize those needs? Does the patient want to have those needs addressed? So what does this sort of look like, and how does you relate this and think about this in the context of healthcare? Again, we could all probably resonate around the idea of maybe having a conversation with this, like with somebody out in the waiting room or something like that. But when it comes into the clinic, the hospital, how do you think about that? Do we have an agenda? Are we trying to, hey, this is what we raise money for, you got to listen to this. Suppose I showed up in your clinic or your ED and I have a pain in my side. So what are you going to do? You're going to work me up. Do a history, physical exam, maybe do some blood work, some imaging. And then if you sort of reached over and you pushed on my side and you said, Bob, does that hurt? And then double over in pain. All right, many of you have already diagnosed me. But you wait for it, and you say, oh, it's your appendix, but probably going to need to have it taken out. But the team, they won't come in until I do the imaging, so we're going to get all that done. And come back in and say, yeah, it's your appendix, and I think you probably need to do surgery. Here's the prognosis, recovery time, and all that. And so what do you think? Ask him for consent. And I look at you and I say, Doc, I ain't having nobody cut on me. Now, do I have a medical need? Do I?
Oh, yeah.
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 Do I apparently recognize that medical need? Now, it's sort of hard to tell, but practically, no. Now, I don't know what it's like in your state, but I live in California. I grew up in Mississippi, but I live in California now. And if I am a sane, competent adult, and there are a lot of people who know me well who dispute whether I am a sane, competent adult. But if I am, you cannot strap me down in the state of California against my will without consent and yank my appendix out. Is that the way it is where you work? Okay, I just wanted to check. Now let's suppose during that visit, after you deal with my appendix or talk to me about my appendix, you start looking at my foot. And you say something about, I hear you mutter something about amputation week at the clinic. And then I hear you say something about complaining about you haven't gotten your quota. What do you call that?
Conflict of interest.
What?
Conflict of interest.
Conflict of interest? Yeah. Well, I know some attorneys that would light up and call it malpractice. Why? Because there's nothing wrong with my foot. There's no indication that my appendix has anything to do with my foot. I don't want to show up at your clinic and have you start creating needs that I don't have. You know, and trying to increase your billing or whatever. And so I tell that story because I think that's sort of a picture of how we talk about doing whole person care. Whole person care is done in the clinical setting in the same way that medical care is done. For the most part, medical care is done in response to a need. Now, I think we could do more in the area of preventative care, but that's a whole nother topic. And so patients come to us with a need. They might not know what the need is. Your job is to assess that need, diagnose that need, come up with a treatment plan. But before you can proceed, the patient has to recognize that need, and they have to want to have that medical need addressed, hence consent. So I think spiritual care can be done in the same way, in response to a need. And I can see the need, but if the patient doesn't see it or the patient doesn't want to go there, I can't force them. If there's not a need, I don't need to try to create a need. That's right. So you sort of see how that works. Now here, I'd like to go back. So you do whole person care with permission, with respect, and with sensitivity. And what I'd like to do is go back to the spiritual history, and I would like everybody to pair up with one person. And we're going to go back to training and do a little bit of role play. And one of you can assume the role of a patient, and the other can assume the role of a healthcare professional. And practice taking a spiritual history. And we'll give you about 10 minutes to do this, 5 minutes each. And just get your feet wet. And then we'll come back together, share a few other things, and then have some Q&A. All right? So everybody get a partner. Let's see. It's going to work out. You're going to be on. Oh, you need a partner? Oh, okay, here. Oh, you're just sitting? Okay, you want to do that? You want to do that? All right, 70
Stressful, yeah. Well, now that arthritis is in me, I don't it just reminds me of the injury. That it's I'll probably
Okay, why don't you switch, please?
She's had but I think some things
Okay, if we could come back together. Sorry to interrupt. So how did that feel? Or what did you think of that?
You know, it's interesting, you don't realize, I mean, I'm not a provider, right, but thinking about an illness and how it impacts so many aspects of even just my thinking about connecting with God. I got an illness, I'm not really thinking about God, I'm just like focused internally.
Okay.
And so asking those questions is like, oh, wait, oh, put God in that space.
Yeah. Other thoughts? Any? Go ahead.
This is a little bit of an American concept. Like I worked in Africa for a time, and they viewed every illness
It is spiritual.
as spiritual.
Yeah.
You know that.
What gods did I make that?
That a guy who got in a car accident and is looked like he'd been tomahawked. And was like, well, I'm so thankful that God has brought me back to this hospital because I used to preach here and used to help as a chaplain, and I haven't done that for years. So God is working in my life in order to, through this accident, to bring me back. He's calling me back to it. And I'm like, whoa.
Yeah.
I view that as bad luck, or you know what I mean? But he viewed it as God's work in my life.
Right. Rich?
It is stressful, I think, to launch into questions.
Mm-hmm. Okay.
You put yourself make yourself vulnerable when you reach out to talk to patients.
Okay. And talk a little bit more about that, making yourself vulnerable.
Well, I think you take a risk that you may get shut down.
Okay.
And
Right.
be refused.
Yeah.
That's not likely from what you said.
Okay.
Many and most patients are willing, the more severe their illness is, more life-threatening, the more they are willing to want to talk.
Sure. Yeah. And I think sometimes I think there is that risk, and I've seen a few patients not respond real well to these questions. These questions I think are general. As people begin to practice whole person care, sometimes they begin to formulate their own questions that are more relevant to their practice, or more relevant to the population that they're dealing with. But overwhelmingly, what I have found when you start asking these types of questions, it signals to the patient that you see them as something more than just a bunch of test results, or a prescription, or just another patient in the long line. It signals that you see them as a person. It signals that you care about things more than just their labs. And they see that, they recognize that, they perceive that, and they greatly appreciate it. But there have been a few times that they haven't appreciated it. Usually, if they haven't, it's just, I'm not into that. And I'm not, again, we're not trying to create anything. We're not trying to manipulate. We're not trying to take the patient where they don't want to go. Any other thoughts? Well, a couple other things. Let me see. Back up to where we are. The JAMA study, they came up with 4 indications, and they came up with 4 recommendations. And top recommendation was training in the area of whole person care. Or is the top or the number one or number two. Years ago, Southern Medical Journal wrote this, and I think it's more true today than it was at that time. Caring about the patient is what gives joy and fulfillment to the practice of medicine, and is why many of you chose this profession. Its absence, especially in the pressured healthcare environment, can rapidly lead to dissatisfaction, emotional exhaustion, and burnout. Practicing whole person medicine is the best kind of care, both for those who receive it and those who give it. And I have found so many people, as they begin to practice this, they say it is life-giving as a provider. And it keeps them going. And many will say that is why I went into healthcare in the first place. But I lost that, or I was discouraged, or I was afraid, or I wasn't sure. In addition to that, Chest noted that interest in the relationship between spirituality, religion, and clinical care has increased in the last 15 years, but clinicians need more concrete guidance about this topic. We could spend an hour talking about that on a basis. We could spend a couple hours talking about the nuances of taking the spiritual history. We could take weeks talking about spiritual intervention. But we just sort of given an overview, and I think you have enough to go back on Monday morning and maybe suggest, challenge, encourage, pick one of those spiritual history questions and try to start asking it of your patients. And maybe initially, I don't care where it goes. I don't care what the patient response is, although I do, but I'm more concerned initially that you just maybe begin try this and practice and work it into your routine and see how it goes for you and see how God might show up. Now that citation gives me an opportunity to make a shameless plug about a couple of things. There's an organization, or there's a clinic downstairs, a neighborhood Christian clinic, that we've worked with. One of our board members started that clinic. But they have joined together with Grand Canyon University. Grand Canyon came with them, and they've put together like this huge video curriculum that is available to you free online that goes through whole person care and spiritual care. There's about 2 courses on it. And if you want to stop by their booth, Gary's going to be around until they start tearing down. And he'd be happy to give you the URL and the resource for that. And you don't have to join anything. You just go to a website and you just watch and listen to your heart's content. Another thing that we do is the whole person care preceptorship. That's something that is for healthcare students. And so healthcare students in the room, listen up. If you know healthcare students, listen. And maybe think about pointing them to this. This is held in Southern California, mid-June to mid-July. This will be the 22nd year that we've done it. We have had students come from some of the best health science campuses in the world to join us for this training. We sort of try to create this optimal spiritual greenhouse effect where students can come in and get spiritually replenished and build incredible community with like-minded students and get some incredible training. Yes, there are didactics and lectures and our faculty or healthcare professionals who are doing this type of thing currently today with their own patients. We have students out shadowing clinicians who are doing whole person care as a part of how they practice medicine. We have them in small group Bible studies that are led by a healthcare professional. We have a relationship with a major medical center, Loma Linda University Medical Center. They are an Adventist institution. We are non-denominational, not Adventist, but we share some common goals in the area of whole person care. And because of that, they allow us access, and we can take those students in and do bedside patients, much like we did with Susie, and practice taking spiritual histories and doing spiritual interventions. And the students are always paired up with another student, and a lot of times they have a coach with them. We have a partnership with SIM where students can do the preceptorship and then get on a plane and go over to Africa and work in some SIM medical mission hospitals. And we hold the preceptorship in Southern California because we have fun. Once or twice a week, once a week we will take an entire day to go have fun. And we'll go and explore California. We'll go to the beach. We might go bike riding down to Coronado or kayaking in Mission Bay or a concert at the Hollywood Bowl. One group ended up at the Grand Canyon one year because we want to have fun. And students need to have fun.
Yeah.
But the other thing is, and they need a break to have fun, but the other thing is having fun gives them more opportunity to build relationships in community with like-minded people that can be an encouragement in this area for the rest of their careers. Everything in healthcare is about outcomes, and what are some of the outcomes in terms of the whole person care preceptorship. And this next slide is for all of you. Bruce Fernando Sabbath came to the preceptorship before he started med school at Johns Hopkins. He is now a pulmonologist at MD Anderson Cancer Center in Houston. Bruce sent this unsolicited text to me a year ago, and he said, what you're doing in training, teaching spiritual care in medical context changed how I practice medicine for all of my career. And then he said, the Lord has brought me into patients' lives often more for the spiritual care than the physical, although he does physical really well. That quote, I am convinced, applies to each one of you who has patient contact. I am absolutely convinced. It's not every patient, it's not every day, it might not ever be every week, but I am convinced that God will bring patients into your life more for the spiritual care than you can provide than the medical. Although the medical is incredibly important, and you need to do that, and you need to do that well, even if they don't want spiritual care, or they don't need spiritual care, or they don't recognize the need for spiritual care. But I am convinced, every one of you, that's true of you. Other preceptorship alums, Helena did the preceptorship, pharmacist, and God called her to go and spend some time in the Dakotas. Why in the Dakotas? To be salt and light work in the Native American healthcare system. Erica Allender was a nurse, preceptorship alum, working at Mayo Clinic. She was doing whole person care, and one of her supervisors was like, what are you doing? And Erica explained it. And her supervisor said, would you be willing to train the 250 professionals on our unit to do whole person care? And she did, and all 250 showed up. The Mayo wanted that for supervisor. Dustin is finishing up doing some work just like you are. They're doing whole person care in Detroit, an underserved setting, and he and his wife are getting ready to go overseas. A bunch of our alums are overseas, many in the 1040 window. A lot of times med students say, I can't do that, I got to do research. We're working on putting a research project together for students who do the preceptorship. I won't match if I do that. Here's a list of students who are matched into incredibly competitive programs who did the preceptorship and delayed or didn't do research. That guy right there matched, on the bottom, matched into ophthalmology. He is from Southern California. At the preceptorship, he met Donata, who was a nursing student from Boston. They fell in love, ended up getting married. They asked me to officiate their ceremony, and I got to do that. And so students, come to the preceptorship. We'll hook you up, get you married. I'll perform the ceremony the last day, and you get to go home.
Yeah.
I've got flyers here. You can grab them, give them, take them, whatever. If you're interested in more, scan that, tell us how to get in touch with you. We'll do that. But questions or comments you have about anything?
On your preceptorship, is it all just Christians?
Christian, it's a Christian program, Christian students, and medicine, nursing, PT, PA, OT, pharmacy, dental hygiene. Basically, anybody that's in a professional training program or accepted into a professional training program is eligible to apply. And this year, I had a guy call and say, I want to provide scholarships. I've been watching this for years. And he said he and his wife will pledge $20,000 last year, this year, and next year. And want you to match that. And so we're able to provide 50% scholarships to everybody we invite to come. Yeah. Other questions or comments?
Any recommendations in regards to documentation as far as you see a patient, you are assessing their spiritual needs,
Yeah.
Yeah, I mean, it's so important to be able to, I mean, we have to document it.
Right, yeah.
But also the spiritual assessment, like, what exactly, like, where did you guys leave off, and how to pick up on the next visit, right where you left off?
You know, I'm not real familiar with the EMR, and so, but I think there are places to do that. There are places to put notes. I think documenting is a great idea because we forget.
Yeah.
And some people have a little code that they use just for shorthand. Other people at one time had a little code to sort of hide it, because, you know, it might be, you know, patient was took a spiritual history, patient was dealing with anxiety, talked a little bit about anxiety, you know, shared some principles of dealing with anxiety or whatever. You know, prayed with the patient, prayed about such and such. Well, yeah, that's confidential. If you want to list that, so that you know where to pick up and carry on. And real quick, one of our alums did residency at Mayo and did HEMONC at Mayo in fellowship, and he had transitioned, I think, off of residency, gone off of a unit, and weeks later he gets this email, and it's from the resident who came on, and it's like, Dr. Shin, I took over your patients, and I saw your notes in the EMR about the patient, about you praying with them, and that was so encouraging to me. And I didn't even know you could do that. And because of your notes, I've started praying with my own patients. And then he went to NIH and he did the same thing, and people often ask him, well, I can't put it in EMR, I'm going to get in trouble or fired. And he said he's never had a problem with it. At Mayo, NIH, one time he got another email from transcriptionist. Dr. Shin, I love transcribing your notes. I love hearing about when you're doing spiritual care with your patients. That is so cool. I'm praying for you. You know. So, yeah, great. Other questions? Yes, sir.
So I work in a children's hospital.
Okay.
I'm a pediatric subspecialist.
Yes.
What about talking to kids?
There's a guy here at Phoenix Children in Cincinnati. And so I think a lot, my peds friends tell me a lot of times the spiritual care is done more with the parents or the families of the patients than the kids themselves. But to your point or your question, you know you need consent, and so I think even asking consent of patient, or parents or guardians, and maybe explaining why you think this is important, and this is maybe a normalizing statement if it's true. This is something I found to be important or helpful. I do this with a lot of my patients, and just wanted to make sure it was okay with you. And maybe if you explain, like to do this assessment and see if there are needs there, and then maybe be available to address those things.
I'm still medical student, but one of the things I saw at the pediatric office outpatient is there's a portion of their exam called like the heads exam, and they start off the visit like with the parent and the child in the group, and then they tell both of them, okay, now there's a portion of the visit that I'm having with the child. But if there's that conversation just between the child, but if it's not, like if it's concerning their safety, then I'll let you know, but otherwise that stays confidential. And so it like brings the expectations for both the child and the patient. This conversation is happening, but unless it needs to be disclosed to the parents, not to me. And I would like to talk about all sorts of things.
Yeah.
That's cool. That's what we do.
Right. Yeah. Thank you. Yes.
Have you ever had a case or heard of a case where somebody's providing spiritual care and it doesn't go well, or it results in any legal action or any of that kind of stuff?
I haven't heard of legal action. I've heard of threats of legal action. My friend that I just referred to, Dave Tejas, ended up in a situation where some of his partners were very uncomfortable with what he was doing and began to complain about it. And over a series of time, this culminated with Dave, some of the partners, I think the department chair, maybe the general counsel, all ended up at the hospital, the office of the hospital CEO. And there was conversation, like one of them said, I've never known when you go down Paul and Tejas is going to be performing mass in the room. And so they talked, and how that ended up being resolved. At one point it came out, one of the guys said, I'm just like incredibly uncomfortable. And somebody says, oh, what's wrong with being uncomfortable? And the room sort of fell silent. But then what else emerged was the reason that the guy that was concerned, had expressed that concern, was he said, I'm afraid I'm going to come in after he goes off, and I'm going to go into the room, and they're going to be expecting me to do that. I don't know anything about that. I don't pray. And ultimately, it was a concern about being seen as a less competent position. Interesting, they didn't have anything to do with the technical and medical stuff. And so what the resolution they came up with was that if Dave did whole person care, he would tell the families, now look, I'm going to be going off. Colleagues are going to be coming in. Not all of my colleagues practice this level of care, this component of care, whole person care. But they are competent physicians. They are going to take care of you. They're going to do their best for you. But they might not do this part. But you'll be fine. And that was an incredible, satisfactory resolution that they all came to agreement on. Fast forward. The guy who lodged the complaint ended up becoming a Christian. And now he practices whole person care himself. He goes on medical mission trips and trains others to do it. But a lot of times when issues have come up, a lot of times there's a misunderstanding. Other times there is that misunderstanding leads to a perception of what happened that didn't happen. And so one of my friends said when somebody got upset with him, they asked him, he got the same question. He said, have you had a negative reaction? I can think of 3. I always went back and tried to work it through with the patient. First, when the patient apologized to me. Second one, we realized it's a misunderstanding. He said, the third one I couldn't find. And then he paused. He said, I've had more negative responses to penicillin than I have whole person care. And then he paused and he said, but you know what? I still use penicillin. Yeah. So anyway, we are out of time. Steve is anxiously waiting us downstairs. Thank you. I'll be around for a few minutes.